I'm a pediatric neurosurgeon, but I also completed a spine fellowship. Um, and that was primarily in adult spine. So I feel like I'm in a great position to look after this transitional patient population from the neurosurgery side, and have very strong interest in spina bifida, because it does cross both worlds. And we've been very innovative here at OU in treating patients that have recurrent tethered cord syndrome, and we can talk about that later on in our webinar as well.
Thank you. Dr. Mims?
Thanks, Dr. J. And again, thanks for you all coming. I'm Catherine Mims. I'm board certified in internal medicine and pediatrics. In regards to the Spina Bifida clinic, I function as the primary care physician for many of these patients. I don't steal patients from anyone, so if they insist on keeping their primary care physician, I'm just there to act as kind of a quarterback in between all of the subspecialists. But I am more than happy to take on anyone as primary care. It's been really fun getting to work with so many of our subspecialists. We have a really great team.
Thank you so much. So to kick it off, Dr. J, can you describe what the transition period typically looks like for patients with spina bifida as they transition between pediatrics and adults care?
Yeah, Claire, I think it may differ with each specialty, but I think in general, in the current state, as kids start to reach adulthood, and we define that kind of arbitrarily at 18 years of age, we start to talk to them about what to expect when they're on their own, what sorts of adult problems they may have related to spina bifida, and we start providing them with a list of adult providers that they may be interested in going to. I think the problem in that paradigm, and I'm definitely interested in hearing what Catherine has to say, as well as our attendees, is that a lot of our adult colleagues, at least in neurosurgery, are not comfortable taking care of patients with spina bifida. That's just something that they haven't been exposed to, probably outside of residency. Meanwhile, in pediatric neurosurgery, we deal with spina bifida day in and day out. So that's the genesis of this new thought of an adult spina bifida program, where we take care of adult patients with spina bifida in the same manner that they were used to being taken care of as a child, in kind of a multidisciplinary setting. So that's what kind of transition of care looks like, current state and future state, or current state now.
Perfect. And you touched on it a little bit, Dr. J, but Dr. Mims, I know there's been a lot of research about kind of the care cliff that happens between a pediatric and adult patients with spina bifida. Can you maybe allude a little bit more to kind of what that care cliff describes, and maybe why you see it exist, or the challenges that you've seen with it in your own practice?
Yes, there is a care cliff at age 18, whether you have spina bifida or not. But it is, there's been a lot of studies that show the more chronic illnesses you have, the steeper that cliff is. And I think that stems from just multiple places. One of them being that many of our patients with spina bifida are reliant upon insurance like Medicaid to help them afford their expensive surgeries and expensive DME. And that insurance changes a little bit once you hit 18. The coverage is different. Your eligibility is a little bit different. So the insurance bit is very challenging. And then pediatricians are very used to taking care of Medicaid patients, and adult patients don't have the same number of physicians that are willing to see them. And so that creates quite the care cliff. Additionally, in pediatrics, we are very kind of whole patient, whole family oriented. We focus on kind of all of the aspects and recognize that there's a lot more to the patient than just the medical illnesses. When you leave the pediatric world and internal medicine, we expect you to be able to sort of like meet us part way as far as getting your care and receiving your care. And patients with spina bifida experience a lot of challenges with that, whether it be from their mobility, their DME needs, sort of a variety of social issues, more complex medical issues than some of the internists like are kind of used to seeing, because they're all congenitally based. And so having a med peds physician, we're like prime sort of PCPs, there just aren't that many of us. And so this clinic is like extremely useful sort of like removing that care cliff. And again, like Dr. J said, sort of giving them that sort of wraparound care that they were used to in pediatrics, and that they honestly like really need to thrive in the adult world also.
That's great. Thank you so much. And so kind of going into that new care model, maybe Dr. J, can you talk a little bit about at OU Health what the care model will look like in our clinic and how it functions, and just especially in contrast to how patients are probably receiving their care right now, maybe a little bit more fragmented?
Yeah, Claire, that's exactly right. I think for adult patients, once they transition out of the pediatric spina bifida clinic, they probably see different specialists at different times. The specialists probably never talk to each other. Maybe a fax goes through once in a while that's either read or not read. In our thinking of what this would look like, it's very much modeled off of the pediatric spina bifida clinic, where there's a physical space that we all share. All the providers are there. Patients are brought in. We each go in and see the patient, and we're able to talk about patients in real time. Probably the key to this whole program is a care coordinator who we have. His name is William Graves, and basically takes all that information that each of us have about the patients and the plans, and make sure that they're followed up on. Dr. Mims also focuses as a very important central figure in this clinic as well. She takes our plans and kind of integrates it into a single clinic note, so that referring physicians, other physicians that deal with these patients know what's going on. So that's what our adult spina bifida clinic looks like.
And I believe we have probably people who've joined this talk who are in the later stages of their pediatric adolescent care and transitioning into adulthood. So what do the challenges look like, perhaps as you get older with spina bifida, and what are some of the things that you're looking for with your colleagues, Dr. J, in that clinic?
So really it's about kind of maintaining patients' health, preventative care. So from a neurosurgery standpoint, we make sure that a lot of the times these patients have shunts in place. So to make sure that there are no signs or symptoms of shunt malfunction. Chiari-2 malformation occurs in about 85% of spina bifida patients. And some of those Chiari-2 symptoms can actually present later in life. So to ask questions about, any problematic Chiari-2 malformation, a syrinx. So a syrinx can happen with Chiari malformation as well as a tethered spinal cord. So to really ask and examine the patient regarding a developing syrinx. And just mentioned tethered cord syndrome. I think that's a big part of adult spina bifida care from a neurosurgery standpoint. A lot of people think that tethered cord really doesn't occur after the patient stops growing, so in this adult population, and that's actually not true. Just having a tethered spinal cord and with the normal movements and going through the daily activities of life can put a stretch on the spinal cord and cause micro trauma that's cumulative over time, and then eventually presents with symptomatic tethered cord syndrome. So tether cord syndrome is a constellation of signs and symptoms that involve back pain, leg weakness, and bowel and bladder issues. So you can tell that kind of spans a lot of disciplines. So that's why it's important to have Dr. Slobodoff in clinic and help you assess bowel and bladder symptoms. To have Dr. Segal, our physiatrist in clinic, to help, determine, are these new limitations that we're seeing in clinic now. So it really works out very, very well.
That's great. And speaking of tether cord syndrome, Dr. J, what are the treatment options that we have at OU Health for tether cord syndrome for adult patients?
Yeah, there's really two options nowadays, Claire. There's a traditional untethering. So traditional untethering is where you go through the previous area of repair, the previous area of untethering, usually in the lower back. So you're going through scar tissue, which itself has poor potential to heal, higher risk of infection, higher risk of spinal fluid leak. So, and then you go down to the dura, or the membrane that covers the neural tissue and holds in the spinal fluid. You open that up and you try to free up the spinal cord as best as possible from the dura. And a lot of the times what you're freeing up is scar tissue, which it's just a normal part of healing. People form scar, and therefore all you've done is start the next time clock to them getting retethered again. And each time you do this tether cord surgery, the risks of surgery go up because the anatomy becomes more and more distorted, but the ability to actually untether the spinal cord decreases. So it's a law of diminishing returns. And I think it was Einstein that said that insanity is defined by doing the same things over and over and over again, but expecting a different result. So that's how I view traditional untethering. Now, the new way of thinking about recurrent tether cord syndrome is spinal column shortening. This really isn't done anywhere else. It's done here and maybe in Philadelphia at Shriner Children's Hospital, and that's pretty much it. And just in a nutshell, that surgery involves working on the bone, working on the vertebra that surrounds the spine, drilling away about 1.5 centimeters of bone, and then closing that gap. So if you view the spinal cord as a rubber band, and when the rubber band is taut, that's tether cord syndrome. It doesn't work well. Spinal column shortening is basically making that distance shorter, taking the tension off the spinal cord, indirectly releasing the tether cord. So that is absolutely an option nowadays, and we follow this procedure very closely. And in our own series, 91% of patients report a relief in pain. These are patient-reported outcomes, not what as we judge as surgeons. 2/3 of patients improve in weakness. 50% of patients subjectively improve in bowel and bladder function. 60%, and that's pretty interesting, 60% improve based on objective testing, urodynamics. So, and then when you compare it historically to traditional untethering, spinal column shortening is equivalent or is superior to the outcomes that you get with traditional untethering.
Wow, that's really interesting. Thank you so much for sharing that, Dr. J. We'll have to dive more into that here in a little bit too. That's super great to hear, especially that we're able to offer such a unique and novel procedure. Also considering things that may be beneficial to be talking with your care team about as you age as a patient with spina bifida. Dr. Mims, what are some common conditions that maybe patients who are getting older with spina bifida should be watching for with their primary care condition? Are there any co-occurring conditions that you want to specifically kind of keep tab on?
Yes, there's a kind of a whole host, and because spina bifida is really a spectrum of issues, kind of the issues that you have to keep tabs on is also a spectrum of issues. Like any adult, we need to screen for hypertension, obesity, diabetes, lipid problems. But because of many patients' lack of mobility or kind of limited mobility, their risk factors for several other things go up, including osteoporosis, chronic pain, chronic wounds, a lot of skin breakdown issues, hypertension, primarily related to kidney function, again, related to neurogenic bladder. So sort of maintaining a really close relationship with urology and making sure that bladder is being emptied routinely to offload the kidneys helps to prevent hypertension. And then again, a lot related to a mobility problem is obesity and diabetes as well. They become somewhat of an issue. And then mood symptoms, depression is very common in patients with spina bifida just because of their chronic pain, chronic immobility, and quality of life problems. So in primary care, we actually spend a great deal of time talking about what is quality of life for that patient and what can we do to maximize that particular quality.
That's great. Another kind of related question is what does it look like as far as exercise and long-term physical therapy that you work with your patients on, or how do you help them best achieve their goals as far as like mobility and staying active goes?
So I do anything that can increase their mobility, from encouraging exercise as I would with anybody, 150 minutes per week, which is like 30 minutes 5 days a week, or I'll do physical therapy, I'll do home PT. I will literally do anything it takes to get them the therapy that they need. Aquatic therapy is highly successful because it removes the weight from the patient. And so that is a really great exercise modality. I spend a lot of time writing as many letters as possible to get them the coverage they need for the therapy, because again, mobility for these patients is one of the primary risk factors for all of the things that I mentioned. So, osteoporosis, chronic pain, chronic wounds, these are all things that are related to having to sit and not move many days, and so if we can improve mobility, their outcomes are definitely going to improve. So I do anything and everything. I encourage a lot of good nutrition with high protein diet, whatever the patient needs. I do it. Now, Dr. Segal, he probably has a better, and here he is, he probably has a better answer for that question other than I tailor it to the patient, but I encourage anything that improves mobility.
That's great. And we also have Dr. Segal, who's a key member of this team, who's able, who was a little iffy on attendance today, who's able to, I know he had some things, but I took the liberty of promoting you to panelist. And so Dr. Segal, I would, if you don't mind, I don't know if you're able to, but would you mind introducing yourself and your role to the group in this clinic? Might not be able to unmute. We'll see. Could be in the middle of something. Oh, there he is.
Okay. Yes. Yes. So I'm a pediatric physiatrist, and this diagnosis kind of is near and dear to my heart because obviously I've had exposure through the continuum from the time of infancy and then through elementary school, young adulthood. And I think the points that have been touched on have been very important towards the role of ours in terms of kind of continuity of care into adulthood. I think one of the biggest things that that really sort of exemplify the importance of what we do is, as Dr. Mims was talking about, that inspiration or motivation towards mobility and really kind of gearing towards more of a lifestyle change. Mm-hmm. And I think one of the biggest things that we recognize, from pediatric age up until adulthood is some of the limitations in terms of coping with the diagnoses and this general kind of mindset of social isolation. And I think that really bears to mind some of the how it escalates the level of impairment with the population, because trying to figure out how to get access to resources that go beyond some of the therapy realm. And this is really where we have to be champions for advocacy to get access to, either through vocational skills, job related training, and recreational activities that can really sort of inspire more regularity in terms of their activity. And obviously from a medical standpoint, I think what's critical to know is the surveillance that needs to be done in terms of skin and wound prevention, because oftentimes they're fitted with durable medical equipment, which is an area that I focus on. And they can lead to significant impairments in terms of wound generation if pressure relief isn't done on a regular basis, or if the equipment is ill-fitting and nobody's been really kind of doing any regular surveillance on that. So those are kind of examples of some of the challenges that are faced relative to that transition into adulthood. And I would add too that there's a degree of impairment just from the cognitive level that needs to be also looked at. So IQ testing is important, and kind of seeing where they may fall in terms of their eligibility for different vocational or job skills.
Well, that's really helpful. Thank you so much, Dr. Segal, for kind of giving that intro and kind of talking a little bit about your role. One question that did come into the chat is from a mom who has a child who is, near the end of their childhood care. And so making that a seamless transition, what are the best steps to start that journey, transitioning from that pediatric to adult care? Like, at what age should she make that appointment, or should she just start broaching that with her child's care team right now? So I don't know, maybe Dr. J, Dr. Mims, if you're able to kind of talk about what that might look like for a patient who's kind of getting close to aging out of pediatrics.
Yeah, that is an amazing question. And I don't have a perfect answer, because unfortunately, my viewpoint, especially as a med-peds physician, is that honestly, we should be doing the transition for you. And that is a point of failure across the country, but there's been lots and lots of data on this, and many med-peds physicians across the country are working on improving transitions, particularly for our higher risk patients. But like I said, all teens are relatively high risk. And so what I recommend, already you're probably an amazing advocate for your child, because you probably had to fight for a lot of things over the last however many years at this point. But I recommend addressing it actually as soon as possible. So if your teen is already 14 or 15, I actually would start the conversation with their pediatrician then, asking, do you know anyone in the system that is familiar with spina bifida, or is at least like confident in dealing with some of the issues that my child has in particular. And then with the subspecialists, and your pediatrician, trying to say, like, is there a way we can coordinate like a packet that we can give in the future to the internist that will help take care of them? I recommend doing that. And then talking with your child and making sure that they're aware that when they turn 18, without signing a form, we can't talk to you as adult physicians without their permission. And so making sure that your child knows like how to get their pharmacy, how to get their medications there, what the number is for the adult doctor. And then your pediatrician probably has an age where they're like, hey, I really wish you would kind of move on to an adult doctor. Many of us do try to hold on to our patients that have more issues to make sure that they get the good transition they need. But a lot of us, that's around 18. And so I try to make an appointment for my pediatric patients with me or with one of my internal medicine colleagues shortly after turning 18 or 19. And I try to kind of compile some some forms if they're not in my system that I think will be helpful to that adult provider to take care of them moving forward. At OU, it's often myself, so I don't usually have to worry as much about it. But I recommend like trying to ask for sort of like the forms that your pediatrician feels like, yes, your adult doctor will absolutely want to know these things about you. So I'm going to make a letter for them just so they kind of know where things are. And then ensuring that if you have Medicaid, that before you can make an appointment with anyone, you are going to have to change the provider on that card. And so if you have an adult clinic, just making sure you call Sooner Care or whatever Medicaid you use and say like, hey, can you change my provider to this adult physician so that I can now go see them? And that is the hardest part to overcome. And once that's done, then usually we can work you in or make it work that way with your pediatrician.
That's a really great point too, Dr. Mims, talking about working with your child's care team to really help develop your child into a strong advocate for themselves as they learn how to navigate the healthcare system with pharmacy and your medical records and involving the appropriate their support system where it makes sense. So that's a really good point. And I'm sure something that with this clinic, and transitioning from pediatrics to adult, that our care team probably works really closely in advocating for our patients for. So that's great. One other question came in, Dr. J, about spinal cord shortening. How do I know if I'm a candidate for that? Like, what's the trigger for understanding if that's an option for me?
So we typically consider spinal column shortening after an attempt of traditional untethering already. There are some exceptional cases where we look at the anatomy, we look at the MRI, and even without undergoing one attempt at traditional untethering, you can tell that the anatomy is such that we probably wouldn't be able to do a good job with traditional untethering. There are no age limits. We've in our series of patients, we've done spinal column shortening from age 5 to 55. So really, it's just a meeting that we can facilitate either in person or by virtual visit, looking at the imaging that's already been done, and then working together with the patient to see if they're a good candidate for spinal column shortening.
Fantastic. Thank you for sharing that. And then the follow-up question to that too is, how long does the recovery period look like for that type of procedure?
Yeah, so what we found was that the length of stay in the hospital was anywhere from 3.5 to 5 days, which again is comparable to traditional untethering, because with traditional untethering, probably for the first 2 days, you'd ask the patient to be flat in bed just to help prevent spinal fluid leak during those 2 days and give wound healing a head start. And then after that, so with spinal column shortening, we wouldn't have that period of laying down in bed. We mobilize the patient immediately, probably home within that 3 to 5 day period of time. We'd ask the patient to take it easy for 3 months, because it takes the bone about 3 months to heal and to fuse. But then after that, normal activities.
Thank you so much. Another question that came into us is, if my child's spina bifida is in, a relatively well-managed state, but when, in their late teens, what does their prognosis look like as they get older? Is there a possibility that they could regress and maybe have worsening conditions over time? Or is there opportunity for improvement? What does that kind of ebb and flow look like over the years of their life?
So I think in one respect, there's kind of a constellation of factors that would be influential in that kind of trajectory or outcome. And I think in some ways it's going to be kind of general health and weight management. And then the other aspects will be kind of the psychosocial portion of that. And if there's any sort of neurologic sequelae, whether do they have a shunt? Are there complications with that shunt? Could they have a syrinx? In general, if there's an ideal situation where none of these comorbidities are really significantly factor in, then we'd look at it from the standpoint of, is there any barriers to their independence? And, is there musculoskeletal issues that come into play? And that would be, related to pain, because with spina bifida, there's generally a muscle imbalance that takes place, and depending on the joint level that we're dealing with, whether it's higher up or hip, knee, ankle, there's certainly some level of orthotic management that we can do to remediate some of that, and still maintain a level of independence. I think around the L3, L4 level is kind of the cutoff where we start to see that level of independence being the major decision maker. But again, there's other aspects from the psychosocial standpoint, and then other comorbidities that have to be factored in relative to that kind of trajectory. And I'll let the other panelists kind of also chime in on this.
Do you want to go first, Dr. J, or you want me to?
No, Catherine, go ahead.
Okay. Yeah, I mean, I agree with everything Dr. Segal has, and I don't know that I have tons to add, but there are some interesting things that can and will probably progress with spina bifida. One of them is like Dr. J mentioned, unfortunately, if there's even like a small amount of cord tethering and we don't know, and it kind of gets all these micro tears, that can definitely worsen, which it will impede mobility or cause neurogenic bladder. And then those are the comorbidities that are going to lead to sort of the other things that I will end up managing, which is hypertension or, poor mobility with chronic wounds, or because of the poor mobility, then, sort of developing a certain amount of obesity, which can be associated with diabetes. So it sort of becomes like a snowball effect. So without having a crystal ball and being able to sort of say like, oh, this is definitely going to happen, our goal with patients who are already like pretty well managed and independent is to maintain them that way. So when you look at the spina bifida guidelines, even with like really mild spina bifida, it's recommended to see a neurosurgeon, urologist, PCP at least annually. And we have a huge benefit having Dr. Segal with us, because his like entire, kind of sort of goal is to maintain you as independent and mobile as possible. And then I kind of deal with some of the fallout that ends up happening if any of those things worsen. And so, I still recommend making sure that they have an adult specialist for each one of their issues, because I think that at least being seen annually and making sure those are not worsening so that we can catch them early is really important.
Yeah, I don't have much more to add from what Dr. Segal and Dr. Mims have already said. I think we already talked about tethered cord can occur at any age, and the only other thing is adult patients can have adult problems such as degenerative spine problems, and you're talking about a spine that is already malformed from a congenital standpoint, where biomechanically there may be stresses where there shouldn't be stresses, and causes kind of this advanced or early arthritis over time that Dr. Segal would help us overlook, and we would certainly check with each visit as well.
Fantastic. And I think you saw this in to our hosted panels. We had a question come in about how to make an appointment, and we'll definitely share that information as well with the larger group of the number to call, but it's really easy. It's 405-271-8888. And Billy Graves is the best person to talk to in that clinic. One question that the mom does have is just wondering, and just for the benefit of the group, is around MACE and mitral and off. And so Dr. J, you did respond that we do treat that, or care for that, but maybe you could just expound on that a little bit, just for the benefit of the group too, and correct my pronunciation of it.
Those are kind of artificial pathways to help maintain bowel and bladder health, and probably Dr. Slobodov, if you were on today, would probably best answer those questions. But I know that our urology group is very advanced and able to take care of every situation that we see in the adult spina bifida clinic, and they perform these procedures as well.
Fantastic. And Dr. Slobodov did send his regards. He got caught up, as I mentioned, with a patient that he could not get out of, but it sounds like too, that's something that being seen in our multidisciplinary care clinic, of course, seeing Dr. J, Dr. Mims and Segal and Dr. Slobodov all in one, he'll be able to answer those questions in person as well. I know we're coming up on our time, but we've had a lot of great questions come in, but I also wanted to open it up to our panelists. If there was any last important thing that we didn't cover that you want to make sure, don't want to put you on the spot, but if there's anything lingering thing that you want our attendees to know, I would definitely welcome the opportunity to share it, whether it's just, you know, reemphasizing the importance of this clinic or maybe something we didn't cover. So I don't know, Dr. J, if you have anything on top of your head that would be important to mention.
No, I think that the most important aspect of this clinic is the fact that it's team-based, which is where medicine is going nowadays. I think the thought that one doctor can handle, you know, the most complex of patients just isn't true. And I think we have to take advantage of each other's knowledge and expertise across the board. And as part of that, to have a central care coordinator, to have a command center, to make sure that our very complex patients are taken care of and labs are followed up on, tests are followed up on. I think that that's what makes our program unique.
Awesome. And Dr. Mims, just, you know, as a primary care physician, transitioning from, you know, peds and to medicine, and just how important PCPs role they play in our lives. I just can't imagine how exciting this is to you to have all the specials that you need right there working with you side by side. So it's probably pretty exciting.
Yeah, it's very exciting. I mean, like I said, being a med peds doc, transitions are near and dear to my heart, but it's even better when I have my subspecialists all at my fingertips and I don't have to worry about a fax being seen or anything. It's so simple to pick up my phone and just like have a conversation about how things are going. Plus, because we sort of see everybody together, it's helpful for me to sort of quarterback the, you know, kind of how is this going to balance with what all the other subspecialists are wanting to do? Is this really working? Is it not working? I mean, it's awesome. This is how we all wish we could take care of all of our patients all the time.
I love that. And then Dr. Segal, is there anything else that would be important that you want the group to know about the clinic, or just, you know, words of encouragement for the transition to adulthood?
Yeah, I mean, I would just echo the sentiments of my partners here. I mean, I am honored and blessed to be able to work with such great team members. You know, I think of this clinic in terms of a vision, and in part the understanding that you know, we are not only just kind of caring from the medical standpoint, but we're also advocates to help the patients really navigate their community and their society, because I think oftentimes, I alluded to this before, social isolation is a significant barrier, and it just leads to a lot of limitations in terms of wanting to access or desire to access the healthcare system, or even looking at trying to figure out how to navigate their own communities. And the identification of resources for the patients that are out there, and trying to partner with some of the community alliances to help, you know, is something that I hope that we can be able to develop. And with this clinic in its infancy, and then as we develop that visibility, we can help partner with some of these community resources that may be in existence, and we just haven't had an opportunity to tap into that, and then foster some of that for the patients that we're seeing. So I'm really excited. I mean, I think this is going to really create a lot of momentum.
Fantastic. And kind of speaking of the community organizations, we have been working with the Oklahoma Spina Bifida Association on sharing information about this clinic and this group, and they've requested that we share the recording of this with them to share in the group. So the link will be sent out via that Facebook group if you're involved in it, and then we'll also share the recording link with all the attendees. But we're very grateful for all the attendees who hopped on today to learn more, and hopefully, you know, and all you do to be an advocate for your children and the loved ones in your life. And then we're also very grateful for our panelists for hopping on and sharing this information about this exciting new clinic. Feel free to reply to the email that we'll send if you have any questions, and we can get you connected with the clinic directly, specifically Billy Gray is the care coordinator, and we'll share all the information about making an appointment. But thank you all so much, and hope you have a great Wednesday. Bye, everybody. Bye.
Bye, thank you.
Thanks.